guys. Today we shall be studying regarding tachyarrhythmias, and the first tachyarrhythmia that we shall be discussing would be atrial fibrillation. Commonest arrhythmia in clinical practice, the sustained arrhythmia is atrial fibrillation. Atrial fibrillation would be characterized by development of abnormal ectopic focus, and this ectopic focus would be concentrated in the left atria of the patient. It has been documented that the atrial muscle, especially where the atrial muscle unites with the pulmonary vein, is responsible for generation of an abnormal focus. What I am trying to say is that if there is structural damage to the left atria of the patient, one of the reasons for structural damage to the left atria of the patient can be mitral stenosis. In a setting of mitral stenosis, the mitral valve opening will be smaller than normal, which will put extra pressure generation in the left atria because the orifice is smaller. This would result in development of stretching of the wall of the left atria. Stretching of the wall of the left atria can result in development of abnormal currents, and these abnormal currents would be referred to as the ectopic focus. The firing rate of this ectopic focus can oscillate anything between 250 to 400 beats per minute. It can be higher also, but the abnormal focus will be firing at a much higher rate. Contrast this with the firing frequency of the SC node. The SC node fires at a rate of maximum only 60 to 80 beats per minute. Therefore, there is a race between the guy in pink, SC node, and the current in blue, and both of them want to reach the AV node. Whosoever will reach the AV node first will control the bundle of his, and whosoever will control the bundle of his will basically become the boss of the heart and will decide the ventricular rate of the patient. In you and me, the ventricular rate is decided by the firing frequency of the SC node because our AV node is captured by the SC node. But in this patient, what will happen will be that the current of the ectopic focus is much more faster and will hit the AV node. Once the current will reach the AV node will exhibit what is known as AV nodal delay. This AV nodal delay is a physiological finding that it tries to slow the amount of conduction through the AV node. But because the number of impulses landing on the AV node is very high, the AV node will try to block some of these impulses because obviously it cannot fire at such a high frequency. All I can say is that there is a limit to the amount of work that can be done by the heart. If you try to push a particular part of the heart, which is the AV node here, to work more than normal, it might not, or it would not be in a position to conduct. Let me say hypothetically, if there are 400 impulses landing on the AV node and the AV node is exhibiting 2:1 block, then meaning of the word 2:1 block will be that the ventricular rate of the patient would be something close to 200 beats per minute. This was purely mathematical. I said if there are 400 beats landing on the AV node every minute, then out of 400 beats, only half of them will be conducted in a downward direction. Therefore, the ventricular rate of the patient would be close to 200 beats per minute. If it is 3:1 block, then only 1/3 impulses will be conducted and the ventricular rate of the patient will change to 133 beats per minute. Let me say hypothetically, if the block is functioning at 4:1, then only 1/4 impulses would be conducted and the ventricular rate would be something like 100 beats per minute. The point is that the ectopic focus exhibits a variable firing frequency, so the block will also be variable. If the block will be variable, the ventricular rate of the patient will also be variable. Ectopic focus is variable, the block is variable, ventricular rate is variable. Because of this variable heart rate, patients of atrial fibrillation exhibit what you study in medical college as irregular heart rate. irregular pulse is a characteristic feature that is seen in patients of atrial fibrillation, and this irregular pulse is generated because of variable firing frequency of the ectopic focus, AV node, and finally the ventricular rate. To get the perspective right, let me say I have a 60-year-old alcoholic. He went to a party where there was free alcohol available. In the setting of free alcohol, he indulged in binge drinking. I am giving the example of alcohol because most patients who are, I would say, hardcore drinkers are suffering from a problem by the name of dilated cardiomyopathy. Now, since this patient is already having dilated cardiomyopathy, that means there is structural damage to the heart. This patient, after imbibing large amount of alcohol, started complaining of palpitations. He complained to his friends that he could feel his heart beating very fast, after which he passed out and became unconscious. Initially, his friends thought that maybe he had too much to drink, but then they realized that they had imbibed the same amount of alcohol. They were okay, whereas this guy passed out. The reason for syncope of this patient was not alcohol consumption in large amount, but a decrease in cardiac output. And the reason for decrease in cardiac output would be that because there is a disproportionate increase in the heart rate of the patient, something like 200 beats per minute, when there is a disproportionate increase in the heart rate of the patient, it results in reduction in the duration of diastole. Now, since filling of the heart occurs during the period of diastole, when diastolic duration will become lesser, the time available for filling of blood in the heart would be lesser, and therefore cardiac output will decrease. When this patient is brought to the hospital, he is not in his senses. As a doctor, you would obviously like to feel the pulse of the patient. And when you put your hand on the pulse, you notice that the pulse was racing and it was not having any rhythm. It was a irregular pulse. In this patient, if you try to record the blood pressure of the patient, the machine will show an error because the machine would not be able to get the or feel the record the pulse. So therefore the blood pressure would either come as error or would be non-recordable. To seal the diagnosis, you have to run the ECG on the patient. When you run the ECG on the patient, instead of a normal P, Q, R, S, T, what you would get in the patient would be the fact that they would be twitching because the impulses are landing on the AV node very fast. The QRS complex will be narrow. They would again be twitching. Then an impulse managed to get across to the AV node and the bundle of his. If you look at the ECG pattern that I have created here before you, the first thing that I would like to highlight in this patient would be that if you compare the RR interval of the rhythm given on the top and the one at the bottom, the RR interval is different. In patients of atrial fibrillation, the RR interval will become reduced, RR interval will be shortened significantly. The second finding that would be seen in the patient would be that the QRS complex of the patient would be a narrow complex QRS. In all of these patients, P wave cannot be made out. So the ECG criteria that are useful for diagnosis of atrial fibrillation are the ones that I have mentioned here. Absent P wave, narrow complex QRS, and RR interval is shortened. In all of these patients, therefore, the first thing that you need to do for the patient is to follow what is known as the RACE protocol. In the RACE protocol, alphabet R would stand for rate control. In the rate control of the patient, we are trying to control the heart rate of the patient or the ventricular rate by using esmolol. When drugs like esmolol were not available, digoxin was being used, but the latest answer for rate control in atrial fibrillation is esmolol. In all patients of atrial fibrillation, the biggest problem is that the atria are twitching, and the twitching of the atria will result in formation of clots of varying sizes in the left atria. If any one of these clots goes into systemic circulation, it would result in development of embolic stroke in the patient. So therefore, because of the clot formation in the atria of the patient, the second thing that needs to be done for all patients of atrial fibrillation after rate control is aggressive anticoagulation. When it comes to anticoagulation, the usual molecule that is to be given or administered to the patient is warfarin. Though instead of warfarin, because warfarin can be associated with intracranial bleeding in case of toxicity and always requires regular INR monitoring, dabigatran or rivaroxaban may be used. Alphabet A stands for anticoagulation, R stands for rate control. Alphabet C for Calcutta would stand for chemical cardioversion. I need to shut down the ectopic focus, and to shut down this ectopic focus in the patient, we can be using a drug by the name of amiodarone. Amiodarone is a class 3 antiarrhythmic and causes prolongation of action potential duration, and by causing prolongation of action potential duration, it will be in a position to reduce the firing frequency, and thereby this ectopic focus will be controlled. So alphabet C would stand for chemical cardioversion. However, if chemical cardioversion fails, then we will have to go in for E, that is electrical cardioversion of the patient. And in electrical cardioversion of the patient, we will have to provide to the patient a DC shock, which will help in termination of this arrhythmia. The most common arrhythmia in clinical practice is best treated by RACE protocol. If they simply ask you what is the drug of choice for atrial fibrillation and not mentioning specific data regarding rate control, anticoagulation, cardioversion or electrical cardioversion, then the drug of choice in the MCQ should be answered as esmolol, because this will slow down the heart. If you slow down the heart, it will increase the cardiac output of the patient, and if the cardiac output will improve, the chances of patient dying due to immediate hemodynamic compromise would always be reduced. This protocol must always be followed. Some doctors always ask me, why don't you start straight away with electrical cardioversion, which could have resulted in termination of arrhythmia? I agree to the fact that if electrical cardioversion is given, it will result in immediate restoration of normal sinus rhythm, but you have to appreciate the fact that all the clots which are present in the left atria are present in the left atria because the atria is twitching and is not contracting. If you will remove the twitching of the atria, when the atria will exhibit a coordinated contraction, it will result in embolization of these clots into systemic circulation and will increase the chances of embolic stroke. I repeat again, if electrical cardioversion is given directly to this patient, the twitching of the atria will stop. Now the atria will start contracting in an orderly fashion, and orderly contraction of the atria will result in dissemination of clots into the systemic circulation. So when it comes to patients of atrial fibrillation, which is the supraventricular tachycardia, we must ensure the fact that electrical cardioversion should only be done provided there are no clots in the left atria of the patient. And if you want to know the presence of clots in the patient, then the test that can be done to